Welcome to Prescribing Lifestyle, the podcast that's all about empowering you to live your healthiest, happiest life. I'm your host, Dr. Avi Charlton, and each week we'll dive into the latest research, practical tips, and inspiring stories to help you optimize your well-being. From nutrition and fitness to mental health and mindfulness, we'll explore every aspect of lifestyle medicine, giving you the tools you need to make informed decisions and take control of your health. Whether you're looking into preventing disease, managing chronic conditions, or simply elevate your quality of life, Prescribing Lifestyle is here to guide you on your journey to wellness. So, sit back, relax, and get ready to embark on this transformative adventure towards a healthier, happier you. Let's dive in. Hello, Prescribing Lifestyle podcast listeners. Welcome to another episode. Today I have Andrea Salcedo, who is a gynecologist who works in California. Welcome, Andrea.
Hi, Dr. Charlton. I'm so happy to be here. I just can't get over how I'm in Southern California. It's in the evening, 8 o'clock at night, and you're in, Melbourne, Australia, and just, at 2-ish in the afternoon. I just think we're so blessed, aren't we, to share and collaborate, I think about where you are. I'm like, wow, you're totally on the opposite corner of the world to me. And this is so awesome to have this opportunity. Thank you.
Yeah, that's it. Yeah. So your summer, we're actually freezing cold winter in Melbourne. It was 0 degrees Celsius this morning.
Oh, wow.
With frost
And
in
it
the
was
grass.
probably around 37 Celsius here in California right now. Real warm.
Wow. So how I met Andrea was last year I went to San Diego Low-Carb USA conference, and we had a dinner together with Tracy McBeath and Angela Stanton. And it was an amazing dinner with Andrea, and we had lots of chats about lots of amazing things and low carb and metabolic health. She's a gynecologist. She has, gynecologist and obstetrician working in Southern California, Loma Linda.
That's right.
Yeah. So I'll get you to introduce yourself and how you got into this space.
Yeah, so you're absolutely right. I'm an assistant professor of OBGYN at Loma Linda University Health in Loma Linda, California, U.S. I've been faculty for over about 10 years now, and I used to work in for a large healthcare organization even before that. And I got into this space because, honestly, when I was a couple years out of training and still getting my footing as a brand new boarded OBGYN, I wanted to have another baby, and I have already had one child, naturally, and for many months, about 18 months, I was trying to have a baby, and I just couldn't. I had regular periods, and it wasn't too painful, but I was starting to get really frustrated about that because I was following all the advice that I give my own patients about lifestyle balance. And at that time, I was eating lots of whole grains and chicken without the skin. And my lifestyle, that was very, very overwhelming. I had a very busy practice. I was working really hard, lots of overnight calls, and very stressed out. But I realized that it might have been the stress that was really impacting my life. And so I quit my job and I went back to teaching medical students and residents how to be OBGYNs. And when I made that transition, I got pregnant like 4 weeks later. And then unfortunately I miscarried, but I didn't even have another period because I had another pregnancy right after that. And so that was super exciting, and how lifestyle really does play a role. But when I got pregnant with my a few years later, I got pregnant with my third, and I ended up finding out that I had gestational diabetes. And at that time, I was probably 62 kilo, about maybe 120 pounds. And I didn't really fit the bill of who would have gestational diabetes. And, I was thin and I appeared healthy, but I had crazy insulin resistance, and my glucose tolerance test was 197, which is really high. And I didn't even have to do our confirmatory test. So I already knew. And a lot of my colleagues and my patients were like, how did you have gestational diabetes? You don't really fit the bill. But I think as I'm understanding metabolic health, it looks like I'm more of the diobesogenic person, that thin person, that TOFI, what we call it, thin on the outside, fat on the inside, where I can fool people with having high glucose levels, even though I'm quite thin. But actually, those people are the worst people. They have some of the worst metabolic health and profiles that we know. And so I kind of fooled my dietitian because she thought I knew about how to do the gestational diabetes diet, and I didn't take any of the classes. But what I had known was I was supposed to eat about 30 grams of carbohydrates, per meal, and I couldn't do that. Every time I would, my sugars were off the chart, and so without her knowing, I started decreasing carbohydrates over and over, and I was actually probably nearly zero by the time my baby was born. And
Wow.
yeah, nobody knew. But that was the only way that I could control my blood sugars. And they were great with that. But as soon as I had one little bit of even like a sliver of a pancake or a piece of bread, my sugars were crazy. And so I
Wow.
thought, well, if my blood sugar is normal, then maybe I don't really need to eat a whole lot of carbohydrates because my
Yep.
body's doing it. And that's kind of how I played out. And I had a normal delivery and it was full term. And but the challenge was a few years later, I started having some pelvic pain and I found that I had endometriosis and I had a big ovarian cyst and I got that removed. But a lot of the a lot of the patterns of what we know with insulin resistance and endometriosis, when we remove an ovary for endometriosis, we recommend that patients be on birth control pills. And, at the time I was considering another baby and I thought, well, like, why would I want to be on birth control pills? I can't, like, maybe I'm interested in conceiving and that doesn't make any sense. And really for the first time, I noticed from patients exactly how they felt when I would give them that advice of here's your birth control pills for your irregular period or your painful period or your heavy period or your endometriosis. And it just, I had two instances where my clinical situation didn't really fit the recommended recommendations of how to treat gestational diabetes, endometriosis. And so I
Yeah.
started doing a lot of reading on my own and I started looking into alternative strategies and really root cause analysis about why disease happens. And I found the Nutrition Network and I found a lot of readings and scientific papers and journals and just looking at old stuff about how we used to do things. And I started studying cultures where they don't have a lot of these problems and looking for the trends of why things improved. And so yeah, and I started becoming an expert of this and learning that really that we talk about end organ damage in medicine, right, Dr. Avi? We talk about,
Mm.
liver disease and kidney disease and diabetics and hypertensives, but
Yeah.
we don't really look at the uterus and the ovaries as recipients of end organ damage, right? We
Yeah.
don't really talk about that. But the same principles of cardiovascular disease, endothelial inflammation, and hyperinsulinemia apply and to the uterus. And so, when we think about the uterus, it's one big smooth muscle. Well, the blood vessels, the veins and arteries are all made of smooth muscles. And so if
Yeah.
we talk about inflammation, then the uterus is going to act very similarly. So then that's why we have heavy periods and fibroids. And so that all was really exciting. So I started writing more and speaking more and doing more conferences. And that's really what my main goal is, to teach women that their menstrual cycle is a vital sign. And if it's painful or heavy or long, that's not normal,
Mm.
and we need to start looking into about why that is. So that's my passion, and that's why I'm
Yeah.
here. And
Wow, there's a
hopefully,
lot of there, there's a lot of things there. It's so interesting. So you think the period's a reflection of how your body's working? How many days do you think is considered as a normal period? How
yeah,
many day
that's a great
cycle, I mean?
question. Yeah, so I can pretty much tell a lot of things about a woman when she tells me about her menstrual history. And
Mm.
really, a normal menstrual cycle should start, on average around 11 or 12 years old. It should occur every 21 to 35 days. It should last about 5 days. And women should be bleeding about 60 cc's of menstrual fluid per
Mm.
episode.
Mm-hmm.
And it will go until the average age of menopause, which is about age 51. So most people that I see in my practice don't really have normal menstrual cycles, and or maybe it is monthly, but it's way heavy. They're flooding, they're going through a pad an hour. And so there's a lot of reasons why that is. And but yeah, that's by and large the menstrual cycle. If it's outside of those things, then we really should be, as healthcare practitioners, be trying to understand why that is and looking into the intricacies of why a woman's body has created this heavy or irregular period. And as you know, Dr. Charlton, there's definitely things like thyroid and prolactin problems that cause some irregularities or premature menopause and stuff. But outside of that, which we know is not common, right? That's not really that common as like a sole problem, that provoked those things to cause an irregular menstrual cycle. Most of the time, what we're seeing is metabolic changes that lead to these things. So
Yeah. So I have a lot of young girls that comes in with very painful periods. Do you think that's part of the spectrum?
yes, it is, and I think a painful period, it shouldn't be that bad. And I mean,
Mm-hmm.
maybe using a little bit of a non-steroidal and, an NSAID and ibuprofen type medication once, through the most painful day is appropriate for just, a little bit of assistance and relief. But outside of that it's not normal. And so if we're having really painful periods, there's a lot of reasons why that is. A lot of times it has to do with body inflammation and you should have a little bit of release of these molecules called prostaglandins, and these are
Mm-hmm.
inflammatory molecules that cause contractions to our uterus to help push out some of these tissues that are within the lining of the uterus. But if your body's under chronic inflammation from a lot of dietary exposures or from chronic stress, then you're going to already have this high elevation of these chronic inflammatory factors circulating anyway. And then when
Yeah.
you have your period, it just elevates that and to a
Mm-hmm.
level that does not feel normal. And so, yes, absolutely. And then there's a lot of reasons why people have, painful periods too. Sometimes it's endometriosis, sometimes it's, uterine fibroids and stuff. But young girls, by and large, it's already their body's already showing them that there is some metabolic imbalance. And truly, I think we don't start looking and taking cardiovascular risk factors seriously until a woman starts to get older, right?
Mm-hmm.
But
Yeah.
the uterus has a wonderful window to demonstrate what is happening at the lining of the uterus, because the lining of the uterus is where all the tiny, tiny blood vessels are. And
Yeah.
if the blood vessels are receiving chronic inflammation, then they're not going to function appropriately. They're not going to constrict. The blood vessels aren't going to constrict to stop bleeding when it's time
Mm-hmm.
because
Yeah.
they're impaired. And so
Mm-hmm.
to have a period that's lasting more than 5 or 6 days is not normal because those blood vessels are impaired. They're not turning off. They're not constricting to stop the bleeding pattern. And so if you're having a painful period because you're flooding at such a young age, already that's a signal that your body's under chronic inflammation. So
And so you think all these young girls is probably eating too much carbs and processed foods and maybe soft drinks as well. That's
absolutely,
causing, yeah,
absolutely. Yes. Yes. And I don't know about your educational system, but in the United States, all those things, all those foods that you mentioned are rampant. They're all over
it is.
the
Yeah.
campuses, and it's just kind of the fun thing to do to eat at those kinds of things at school because your parents aren't around, and they're not there to monitor that, and maybe even the parents don't even understand how that
Yes.
impacts health. And a lot of folks really kind of accept that, right? They're like, oh,
That's
it's
right.
just they're teenagers, they eat junk. But I would assert that, we need to remove that from women because if we're already causing problems with the structures and the microstructures of a woman's body at that age, they might not repair itself. It might not, they might be, you know,
Mm,
they might have to deal with heavy periods for a much longer time than they should if they were able to prevent and not have any of those processed foods and high
mm.
carbohydrate foods in the first place.
Yeah, yeah. In Australia, the education system doesn't supply them with lunch, but the teens are pretty bad with eating junk food, soft drinks, and they buy it
Yes.
themselves, and the parents certainly provide it to them. So yeah, it's
Oh
pretty
yeah,
sad.
and then because it's easy, right? It's like really hard to send your kids to school with a healthy lunch, right? I
Yeah,
struggle
yeah.
with, I've got three boys, and it's really hard to send them with a thermos of something good, and then they're like complaining that it's not as good as it was yesterday, and it's like half eaten. And so then of course like parents like send them with, chips and crisps and all those things that are shelf stable but terribly unhealthy.
Yes,
Absolutely.
absolutely.
There's so many layers.
Yeah, absolutely. So you were talking about the young girls having irregular periods that could be caused by the diet. What other conditions do you think that the women might have that could be because of the modern diet, like endometriosis and polycystic ovarian syndrome? Are those are related to
Yeah.
our diet as well?
Yes, absolutely. You know what, kind of the first stages of these irregularities that happen. So first off, the first year or two, when after a young girl goes through her first period, sometimes they're going to have some irregularity because the signals of the brain to the ovaries are still kind of getting used to normal signaling. And a young girl may skip a period here and there, and that's very normal. But after it's been 2 years since she's had her first menstrual cycle, it should be every month like clockwork. And so, an interesting thing that happens if that there's too much insulin being secreted in your body because of chronic consumption of carbohydrates. Any carbohydrate will do this. It's even whole grains, even legumes, even beans and rice and bread. Your body doesn't really discriminate. And so whether it's low glycemic index, high glycemic index, a carb is a carb, and it's going to raise your insulin levels. And remember, insulin is a stress hormone. It is we think about it in terms of diabetes, but insulin's a stress hormone, and women's bodies are, for better or for worse, we're kind of made biologically to have babies, right? And so if our body senses a threat of anything that's going to cause a threat to our ability to conceive, it's going to shut down our menstrual cycle and protect us from getting pregnant at a time that's not safe, right? Because we know that the biologic commitment and resources involved in having a child for those first few years is easily 3 years. Like it's like 1 year of being pregnant and 2 years of serious child rearing, breastfeeding, and really just focus on the child. And so your body knows that if you're under a stressful time in your life, it's going to shut down your cycle to protect you from having a baby at a time that's not right. And so even, stress will do this. We know this, right? If you're going through final examinations, there's a death in the family, women will miss their period and they're like, oh yeah, it's because I was stressed out. And everyone kind of
Mhm.
feels comfortable with that. But
Yeah.
another stress is just nutritional stress. If we're eating too many carbs, your insulin level goes up. Your insulin level goes up with all those other lifestyle stressors too. And it actually shuts down the signals of ovulation from your brain to your ovaries. And so if it shuts down that signal, then you're not going to have a period. And for a long period of time, that can increase a woman's risk for, uterine cancer, 10, 15 years down the line of having these chronic elevations of insulin that prevents women from having their menstrual cycle. So, that's one thing, and that's one pathway of how that goes. But then we also know that endometriosis is another chronic inflammatory condition. But yeah, do you have any questions about that PCOS pathway though, before we
Yeah.
talk about
So
endometriosis?
yeah. So the polycystic ovarian syndrome is more caused by the high insulin, and the body shuts it down and doesn't want to have regular periods. That's how I understand polycystic ovarian syndrome.
That's pretty much it. I mean, there's a lot of organizational bodies that fight over these criterias of
Mm,
polycystic ovary syndrome, and really it's irregular periods and hair or excess
yeah,
testosterone, hair where you
yeah.
don't want it, and excess testosterone, and then tiny cysts on the ovaries, and that
Mm,
are we can see on ultrasound that don't require surgery, but these tiny cysts are just demonstrations that your body's trying to ovulate, but it can't get that right
uh,
signal. And
yeah.
then the elevations in testosterone come from the high insulin levels, because there's more circulating hormone around, because it's affecting your liver to reduce the amount of something called sex hormone binding globulin, which is a protein that binds to all of our circulating hormones and
Mm,
inactivates them a little bit. But if we have less of that sex hormone binding globulin because of high insulin levels, then you have more of that circulating testosterone, and that's why people get more acne and
Yeah,
chin
yeah.
hair and and abdominal hair and thickening on their neck and stuff. And so all of those signs, will bring women to that polycystic ovarian syndrome phenotype, that
Mhm.
expression, that physical
Mm,
expression. And the organizational bodies say that you need two of those three criteria to meet criteria, but a syndrome is a syndrome, and that means that you don't
mm,
always have every criteria every time you check. Your body just kind of comes and goes depending on its exposure. And so when people say, "Oh, my doctor told me I didn't have PCOS because I didn't meet these criteria," but you're looking at them and they've got chin hair, and acanthosis,
mm.
they've got that velvety neck area, and you're like, well, you probably don't have a testosterone secreting tumor, but we can check that. It's likely that just this last few months you don't really meet criteria, but you probably have that expression. And so,
It's so interesting. I've had patients that had polycystic ovarian syndrome and suffered from infertility for years, and I put them on a low carb diet, and they lose a little bit of weight, and then they began to fall pregnant. It's such an amazing
yes,
experience. Yeah, very,
yes, and
very
all from that
rewarding.
insulin, right? Yes, all decreasing insulin, and all of a sudden your body feels safe to ovulate again.
Yeah, they start having periods and fall pregnant. That
Yes.
was very memorable. I still remember that particular patient who I helped
Oh,
to fall pregnant.
oh, that's great.
Yeah, yeah. So tell us about endometriosis. How does that relate to diet and lifestyle?
Yes, endometriosis is one of those very challenging diagnoses to treat for general practitioners,
Mm,
OBGYNs. And the reason why it is so challenging is because it is exceedingly hard to diagnose without even a surgical, diagnosis. But what we're knowing is that endometriosis is a chronic inflammatory condition that involves um, the um, the lining of the uterus that tends to escape and tends to be implanted in various locations of a woman's body, most likely in their pelvis and in their abdomen. But there's really unusual case reports of endometriosis implants found in like a woman's brain or in the lungs and or even in the eye. I mean, really strange places. And so because of that, there's been several theories about why endometriosis has come to be, and no one has really accepted any real prevailing theory, but there is one theory called Sampson's theory of retrograde menstruation that looks at the concept of when a woman has her menstrual cycle, our blood comes out through the vagina, from the cervix through the vagina and out, but it also comes out through the fallopian tubes.
mhm,
And as it's coming out through the fallopian tubes, it implants into, or actually it comes out through the fallopian tubes and it rests within our pelvis, and our normal immune system will process the debris, the menstrual debris that's in our pelvis. And most of the time that blood sits at the space between our rectum and our vagina and in that area. And that's why some people have some discomfort during their menstrual cycle in that area. But in endometriosis, the pain is very excessive and it's chronic, and it comes with a lot of bloating and severe pain that a lot of times can be frustrating because sometimes ultrasound doesn't really find these implants, and even sometimes surgically we look and we don't really see a whole lot, or we see just scarring, but we don't see implants. And sometimes we see these endometriosis cysts on the ovaries, and that makes people feel, and that's exactly what happened to me. That's how I found out I had endometriosis. But
mhm,
sometimes it's very frustrating because patients don't really have clear answers about do I or don't I, but they have really painful periods. They have pain when they have a bowel movement on their period. They have pain with intercourse all the
mhm,
time. They have constant bloating and fatigue and just a pain that doesn't get alleviated by our normal anti-inflammatory medications. And so a lot of times doctors just end up putting them on birth control that helps stabilize the lining of the uterus. So when they do bleed, it's not so much. But here's the interesting thing, and this is where it became a passion project of mine, is that in 2015 in the American in the Green Journal, which is the OBGYN journal, a big journal that the American College of OBGYNs subscribe to in the United States. And it called for an understanding that it's very possible that endometriosis comes from a gut microbiome imbalance. And that imbalance allows leakage of inflammation molecules from our intestines to leak down into our pelvis. And so when we break down that gut barrier, it allows for inflammatory molecules and bacteria to get into our pelvic cavity to cause a lot of inflammation. And then our immune system attempts to process those alien particles that are there. And so our immune system is chronically elevated, and so it's processing, and there's all these immune cells that are there to help with that. But then we have our menstrual cycle, right? And we have that retrograde menstruation. And so then the cells of the lining of the uterus implant into the pelvic cavity. And then we have the activated immune system already from the gut dysbiosis, but then we have menstrual cells there. And because we have these active inflammatory factors together, it actually causes new blood supply between our pelvic cavity and the organs around it with the menstrual cells that are already there. And then they kind of implant, and then they receive the same signals of estrogen and progesterone in menstrual signaling. And then they bleed just like every other menstrual cell in the lining of the uterus, but it's bleeding from the intestines, or it's bleeding from the diaphragm, and it's bleeding from the space between the rectum and the vagina. And it's exceedingly painful. And it's just this cycle that keeps going. And so what we're finding out, and this is kind of how I treat a lot of my patients with endometriosis, is to treat the gut problem, right? And if we treat the gut problem with, organ meats, with vitamin A, with carnivore style diets to heal the gut microbiome, oh, wow, they do so well. I mean, I even give patients cod liver oil, and cod liver oil has omega-3 fatty acid. It has a small amount of vitamin D, and it has vitamin A. And vitamin A is like a prebiotic. It's like a precursor for all of our healthy our healthy bacteria in our gut, and it helps with immune system processing. And so I've just given cod liver oil to patients with endometriosis, and it's kind of like magic. It works so really well. And so, so well that I'm getting ready to start writing a randomized controlled clinical trial, because it is incredibly successful. And there's lots of data on this. There's a lot of really great data for cod liver oil in the setting of endometriosis. And just look it up on, any of your scientific website or, search engines, you'll find it. And so this is new. This is like maybe 8 years old, this association between gut microbiome disturbance as the leading cause of endometriosis. And it's very exciting times, because, if we approach it in that way, then patients are exceedingly happy about the results. It takes a while, right? It's not as overnight as like birth control. But if folks are looking for a long-term solution that involves some diet strategy, you can see lots of improvement in this chronic disease. So yeah, that's endometriosis.
That is amazing. I've learned so much. I've never been taught about this, but I have listened to it on your YouTube channel about this before. But it's great to hear it again and learn from you about your experience. That's amazing. Yeah, great.
Yes.
That's good.
Yes, I know. It's really exciting. I think that when we find potential solutions for problems that cause a tremendous amount of patient dissatisfaction and provider dissatisfaction, right? Because a lot of times doctors and patients really don't like trying to seek care for particularly endometriosis, because they run into so many roadblocks, or patients feel like nobody's listening to them. I mean, for women, many women have had like 7 years of trying to get a good diagnosis. And then when they do, then they're unhappy about their plan of care, and how birth control doesn't seem like the right answer. And it may help a little bit, of course, with reducing some of the level of bleeding, but it's not it doesn't treat the cause,
No,
right?
that's
And if
right.
we're all about root cause, treatment, then sometimes the hard work of changing our diet and looking at all those inflammatory players, things like smoking will do that,
Mm-hmm.
trauma, adverse childhood experiences because of the gut, the
Mm-hmm.
neuropsychologic, immunologic connection. So
Mm-hmm.
these really challenging discussions are very important, but we have to be very comprehensive at trying to figure out what the inflammatory trigger is for someone, right? Because sometimes the people are on a really great diet and you're like, well, it's not processed food. What is it? And we have to look at other provoking factors of inflammation. And, are they night shift workers? Do they
Mm-hmm.
get enough sleep? Are they vitamin deficient? Are they undergoing chronic stress? Are they in a very domestic abusive relationship? All of these things that raise our catecholamines, that cause chronic inflammation and adrenaline in our body, which leads to high glucose, which leads to high insulin,
Mm-hmm.
and so yeah. It's
Wow.
not a one size fits all approach, right, doctor?
No, no, very interesting. Um, I just might ask you about menopause quickly because a lot of my listeners are perimenopause or even postmenopause. How do
Yeah.
you manage their symptoms in a
Yes.
natural lifestyle way?
Yes. So what we do know about the perimenopause and menopause, it is a 10-year process from when your body starts to initiate the, anovulation, that, when a woman's not ovulating every month because of the egg quality is not as great, or because it's not receiving the proper signals. And so the average age of menopause is 51, but that process can be a little bit earlier for some people. And we do know that insulin resistance can cause a lot of worsening vasomotor symptoms. So those hot flashes, that irritability, the difficulty sleeping, the inability to cope with normal stressors that they maybe had before, the insomnia. We do know that insulin resistance plays a huge role in that. And the reason why it does is because if we already have that predisposition, or if we're already experiencing high glucose or high insulin levels, when we go through the change of life, that low estrogen level from the lesser secretion of estrogen from our ovaries will actually restructure our adipose tissue, our fatty tissue from our legs and our bottom and it changes and moves it over to our abdomen. And it turns into what we call visceral adiposity. And that visceral adiposity is way more inflammatory than the adipose that was in our hips and thighs. And then that high inflammation, that visceral adiposity causes way more insulin resistance. And so then that's why a lot of women experience worsening of those vasomotor symptoms that we see in menopause and perimenopause. And so a lot of women who are metabolically healthy experience very little of these unwanted symptoms that are related to menopause. And they do quite well. But some people who struggle metabolically have these very difficult hot flashes where they're drenching their clothes at night. They have to change their clothes because they're so wet, and they can't sleep. And so that if they control their glucose levels and adhere to a low carb diet, that really does help because it addresses the root cause physiology. A lot of people will also, incorporate a little bit of estrogen and progesterone hormone replacement therapy, and that's also very reasonable to ease that abrupt change in hormones. And that's definitely an individual decision between the patient and the doctor, and there's some contraindications there that need to be reviewed. But by and large, when ladies use hormone replacement therapy, it's very, very helpful with reducing those hot flashes and those under the surface side effects, those soft side effects of insomnia and irritability and kind of anxiety that come with the perimenopause time. So yeah, but it's all about, even menopause, you got to decrease your carbs because people start gaining weight even more at that time.
Yeah, so many gynecological conditions are related to insulin resistance and inflammation.
That's
I think,
right.
yeah, more than the normal people would think about. Most people wouldn't know that endometriosis and menopause is related to insulin.
That's right. That's right. There's so many things, so many, things that cause restructuring and problems with the structure and function of our organs that are related to inflammation and high insulin levels. And it's very subtle, right? These problems are subtle. They're not, easily treated. It's not like you have a pneumonia or a bladder infection and here's your antibiotic, you get better. The treatment for these things and actually the pathophysiology, the development of these things are day by day, hour by hour, year by year. And then,
Wow.
and then we get to where we are. And so the treatment is quick. When you do make these lifestyle changes, it does happen quick, meaning like, over months to years, your body does get better. But, it just takes some time and patience, but it is definitely the way to go.
Yeah, absolutely. So what are the simple everyday changes that you advise to women to help with these conditions?
Yeah, I think really just kind of watching your carbohydrate intake. I mean, I'm certainly not carnivore. I really try to
Mhm.
get, when I eat my meals, most of the time I don't really eat breakfast because I'm not too hungry in the
Mhm.
morning. But I have a really good lunch and dinner, and I probably eat about 30 grams of carbohydrates per meal or less. That's kind of what I try to shoot for. I probably eat a lot less, but that's what I shoot for. And I, eat vegetables and sometimes I'll have a little bit of fruit or even maybe some, good quality ice cream and that kind of stuff once in a while. But by and large, I eat a lot, and I would recommend, a lot of good, healthy protein, fats, and animal proteins for sure, and seafoods and things like that, and because they're very, very healthy. And I also recommend that I know women right now are fasting, and that's a big deal that women are looking to fasting, but I would just not recommend fasting the week before your menstrual cycle or on your menstrual cycle, just because that week before your menstrual cycle, your body's preparing for the stressor of
Mhm.
menses and blood loss and stuff. And so you don't want to activate your cortisol levels too high during that time. And you definitely don't want to try to fast, too long while you're on your menstrual cycle too, because your body's losing electrolytes as with the menstrual blood, and so you want to really stay hydrated and add your electrolytes too. Um, but those other 2 weeks, I think it's absolutely safe to fast, and 18-hour fasts I think are just fine. And I think longer than that, it really just depends on why you're trying to do it. And if you're excessively, overweight or obese, I think there's a role for that. But if you're of normal body weight, you really don't need to fast all the time, more than 18 hours, and definitely not that week before your menstrual cycle or on your menstrual cycle.
That's great. So that's lots of practical advice. So go low carb and fast sometimes, but not fast before your period for the week.
That's right.
Yeah,
That's
there's
right.
lots of great advice. And Andrea, yeah, I can talk to you all day, but I'm
I
just
know, right? We
aware
could just talk.
I'm just aware of the time because it's almost 9 o'clock in your time, and
That's
I would
right.
want
That's right.
I would want to go to bed if it was me. So
Yeah, well, we're
yeah,
getting ready over here, so.
yeah, we might wrap it up because so people can find you on YouTube. I've been listening to your videos on YouTube. Tell us a bit more about that.
Yeah, so I have a very fledgling YouTube channel. It's called Conscious Gynecologist, and it's I try to post at least monthly of something new and interesting, and it's really exciting. It has a lot of these discussions that we've talked about, and root cause analysis and pathophysiology of how medical gynecologic problems come to be. And if you're ever in Southern California and California, I do have an upcoming online telehealth metabolic practice for patients that are within the state of California. You don't have to be a resident, but if you're ever there, we can definitely do something. And so check out my YouTube channel for more updates on that. But yeah, but basically my YouTube channel is the best way. And of course, You can also send me an email if you have any, non-specific educational questions. Obviously, I can't give any real medical advice that in these capacities, but, consciousgynecology@gmail.com is my email address, consciousgynecology@gmail.com. And I'm always open for chatting or, kind of brainstorming ideas of how to help women.
Great. Okay, thank you so much, Andrea, for coming onto the podcast and sharing all your knowledge with the listeners. That is awesome. I'm sure I've learned a lot as well.
So I'm glad. Anytime. Thank you for the honor of being here, and good luck to your practice. You're doing really great things and continue to be a trailblazer in, the medical system in Australia, but also you're influencing other GPs around the world to take the leap that you're doing. So bravo.
Thank you. Thank you so much. Thanks for your time. Thank you
Absolutely.
for listening, your listeners. Until next time, we'll invite another guest into Prescribing Lifestyle Podcast.
Thank you for tuning in to another episode of Prescribing Lifestyle Podcast. Before we wrap up, I have an exciting news to share. I have a new ebook called Low Carb Made Easy. It's now available. This guide is perfect for anyone looking to dive into the low carb lifestyle. Inside, you'll find the basic theory behind low carb eating, a detailed food list, practical meal plan, and a variety of delicious recipes. It's designed to make a journey to better health easier, simpler, and enjoyable. For those who prefer a hard copy, head over to my website and register your interest using the link provided. My website is www.mlcclinic.com.au. Head to online store. Remember, the information shared in this podcast, it's for educational purposes only and not proper medical advice. Always consult your medical professional before making any changes to your lifestyle and diet, or you can come and see me in Melbourne Low Carb Clinic. If you enjoyed this episode, don't forget to subscribe, leave a review, and stay connected with us on social media. Your feedback will help us improve and reach more listeners. Lastly, if you found this episode helpful, please share it with your friends and family. Together, we can make a positive impact to our health and our communities. Thanks again for listening, and as always, stay healthy and happy. Until next time.